right. Thank you everyone for joining. I'm Padraic O'Malley. I'm a urological oncologist at the University of Florida. I'm going to moderate this little short 1 hour session we have. We're going to talk about a couple of topics in kidney cancer. The first half is going to focus a bit on imaging and some of the controversies or some of the misnames around imaging and some of the utility of some of the imaging modalities, such as PET scans. Won't focus specifically just on PET scans alone, but that's one of the topics we'll talk about. And then the second half, such as radiation for the treatment of kidney cancer historically, and what's emerging as new roles for radiation. So with that, I'll go ahead and just introduce our panel of experts today that have joined us from across the country. First off is Dr. Tyler Robin. He's a radiation oncologist at the University of Colorado Anschutz campus at the School of Medicine out there. He's a radiation oncologist who does a lot of kidney cancer. And I've been fortunate to work on with a couple of different topics. So he's joined us from Denver, PA. Dr. Logan Zemp is a urological oncologist like myself. He's based out of the Moffitt Cancer Center here in Florida as well. And obviously has done given some nice talks before on head imaging and kidney cancer, and so I've asked him to join us today. And Dr. Janaki Sharma, who's from the University of Miami School of Medicine, Middle School of Medicine, who's a medical oncologist, so she'll keep us surgeons in check a bit. And she has basically joined us. And we have one other panelist who may or may not be able to join us, Dr. Ray McKay, who's at the University of California, San Diego, but she is kind of tied up at the moment at the Medical Society of Clinical Oncologists with some responsibilities there. So that's running a little bit late. So she may or may not be able to join us. But guys, we have a great panel, and so that's interesting things to discuss today. So thank you all for joining us. We'll run through some of these topics a bit, and then we'll probably the sort of the two halves of the discussion today. We'll try and leave a bit of time to allow people to ask questions, and give an opportunity to sort of maybe if there's some specific things you want to drill down on a bit, we can talk a little bit about those as well. So the first thing we're going to talk about is sort of two things. One is the emerging role of PET imaging in kidney cancer. And the other one is the risk of, contrast and imaging scans in kidney cancer. Many of you who have kidney cancer probably know, oftentimes you get CAT scans or what have you. And those are often done with contrast dyes. And oftentimes your primary care or your nephrologist or other physicians can have, even your urologists and medical oncologists can have concerns about, is there potential for damage to your kidneys? Obviously, from an imaging point of view, having the contrast in the scans gives us much better pictures and images to guide your cancer care, but there are limitations to what we can and can't use. So just to put this in context, most patients when they come in, many of you will present to surgeons like myself and Dr. Zemp. So we'll start with Dr. Zemp. When you get patients who come in, say with renal masses that are on the smaller side versus the larger size, what's the typical imaging modalities you get for your patients?
Yeah, thanks. Thanks for having me. It's a pleasure to be here. So I see a lot of patients that come into my clinic with, renal masses. They may show up with varying different imaging modalities. They've had an ultrasound, or they've had, a scan because they had some blood in the urine. They thought it might be stones. But really, if we're looking for a small kidney mass or even a large kidney mass, we want to be able to evaluate both the primary area and metastatic evaluation. So if it's a small kidney tumor or a small mass, then we get a contrast-enhanced CT scan as long as their renal function is appropriate or the kidney function is appropriate, and then a chest x-ray. But if they have a larger mass, then we still get that contrast-enhanced abdominal pelvic CT scan looking for what the primary is. But we also add, instead of a chest x-rays, a CT scan of their thorax or their chest. And that doesn't necessarily have to be with contrast.
I would say, someone who sees a very similar population to you, those initial presentations, that's what, most of us would say is, CT of the abdomen, pelvis, but either chest X-ray or a CT of the chest, depending on the size or how advanced the disease may be. Now, obviously, Dr. Sharma sees, many similar patients, but she also sees patients who are maybe more advanced in some cases. And so, Dr. Sharma, is there any other additional imaging here that you look at in select patients who may have specific concerns, and that's just bony lesions or brain mets?
Absolutely. So, as many of you know, when kidney cancer spreads outside of the kidney, it has a predilection for certain places over others. And so around a third of patients that have metastatic disease will have it in the bones. And CT scans are not necessarily the best imaging modality for that. So we will often do a bone scan in patients that we have concern for bone disease in. And as we'll talk about a little bit more, we're also starting to use PET scans more, as there might be a little bit more sensitivity for the PET scan with bone disease. The other area that's a little bit different, controversial amongst medical oncologists, is whether we should be doing MRIs of the brain on all patients that have metastatic kidney cancer. And I think you'll find the whole gamut of opinions here. But, as around 10% of patients do have brain mets. And if it's something we can catch early, we prefer to do so. So they're, more often than not, I think at least once in the course of, you're the metastatic diagnosis, we are getting a brain MRI.
So, obviously, I think I touched on it, and Dr. Zemp, you touched on it too, is, some patients who come in obviously have that impaired renal function. Do you have, standardized approach, is MRI you always go to, or how do you sort of counsel or manage patients in that regard?
Yeah, and so the big concern is that they'll have something called contrast-induced nephropathy or post-contrast associated acute kidney injury. It really depends on what patient's kidney function is coming in. So I think the guidelines would recommend if somebody has a GFR greater than 40, that they could just get some fluid volume expansion through an IV and get a CT scan. Otherwise, there are lots of great options with MRI with some of these some new gadolinium agents. They're called group 2 and group 3 agents. They don't have any of these same effects, and it's really rare for people to have issues with them. So those are usually the modality that we go through.
Okay, very good. I see a comment there that the audio quality from my end may be a little bit muddled or difficult to understand. That may also be me. I tend to mumble a bit. So I'll try and be a little clearer for you. Dr. Sharma, what are some of the misconceptions that you see in regards to contrast imaging amongst patients and also amongst physicians?
So I think, contrast has undergone kind of a revolution over the last 15 to 20 years. So what held true about the contrast of the 1990s is not really true anymore. And I think patients and a lot of community physicians also hold on to those same misconceptions. I think for patients, one of the biggest misconceptions is that all contrast is the same. So you've been told that you have chronic kidney disease and you shouldn't have CT contrast. But that doesn't necessarily mean that MRI contrast is potentially harmful in the same way. And the IV injection that's given with PET CTs is completely different from contrast. So even though they're all kind of called contrast, they each have their own set of risks. And as we get further along, the risks are getting less and less with each of these agents. And I think we'll probably talk a little bit more about that as we move along.
Yeah, so I think, Dr. Zemp mentioned the sort of contrast-induced nephropathy was the sort of term we used before. Now we use this sort of post-contrast acute kidney injury. The contrast agents, as mentioned, are very different nowadays than they used to be. And one of the easy outs that we've always used is an MRI. But Rob, I know you use MRI in many of your patients, and I think you even have an algorithm that you use MRI imaging to sort of predict, what the etiology of the masses may be as well.
Yeah, CT and MRI are both good imaging modalities for looking at a small or medium-sized renal mass. So, and so I'm a radiation oncologist for localized renal cell carcinoma. I usually come into play when we're talking about using radiation. in lieu of, say, a partial nephrectomy or a type of thermal ablation like cryotherapy or microwave or radiofrequency ablation. And in an ideal world, all of these kidney tumors have been biopsied prior to coming to me, and so we know exactly what we're dealing with, that for sure it's a malignant kidney tumor, and that it's of a histology that we expect to respond well to radiation treatment or that warrants treatment. But not all patients can undergo a biopsy. Some tumors are not in a good location to biopsy. And some patients honestly want to avoid the invasive procedure of a biopsy and the risks that come with it if possible. So in that scenario, for solid kidney tumors, there is a algorithm developed by the group at UT Southwestern that uses MRI to basically give a likelihood score. So how likely is the small tumor on imaging likely to be a clear cell renal cell carcinoma, being something that we want to treat. So for patients where we either can't get a biopsy or are hesitant to do a biopsy, I like MRI for that reason. I think it adds a little bit of extra information. But for many, tumor CT is sufficient.
So I think, all those things, the sort of better predictability of the imaging modalities, and then also the changes in the contrast and how we're managing that, and being cognizant of what the actual side effects really are. I know for the gadolinium agents, as you mentioned, Dr. Sharma, they're now the second and third generation. There was updated consensus statements on that a couple of years ago. And, for instance, in the grade 2 gadolinium agents with patients with GFRs less than 30, which are very poor kidney function in many of those, the risk of nephrogenic systemic fibrosis, it's on 0 cases out of 5,000 administrations. So I think the tools we're using are getting better and better. I think that's going to be less of an issue going forward. Now, CT and MRI are kind of what we refer to as structural imaging. They give a lot of information about the structure of the anatomy. So as surgeons and as a radiation oncologist, we like that because it tells us where things are in relationship to one another. Dr. Zemp, can you explain a little bit about how PET works and how it's more of a functional imaging modality?
Yeah. So often you'll see like the marrying of the two, the CT scan and the PET scan. So you get this structural image, then overlaid, you'll get this PET scan, which is a positron emission tomography. So essentially you get a radio tracer placed through the bloodstream. And the most traditional one is our FDG PET, which is like a radio-labeled sugar molecule. And essentially, this will go to areas that have high activity. So like in this scenario where we're talking about kidney cancer, then it could go to kidney cancer. This is a little bit of a tricky subject with kidney cancer itself. And I'm not sure if you want me to talk about that right now. But essentially what we're looking for is that, things that might be more active or high activity, like cancer cells, will light up.
So I think, the PET scans that most patients have received for other types of cancers, and in general, they think about it as sort of the PET FDG, which is sort of it's used for many types of different cancers, and some of those cancers are exceptionally good. One of the problems that you kind of relate to is that kidney cancer, it can be a bit hit or miss. Sometimes it actually can be a very good marker, but other times it's a bit poor.
Yeah.
But what we've seen in the last couple of years is we've seen PET scans that can be a bit specific for the type of cancer an individual has. So, for instance, there are what I call PET donated scans that could be used for some types of neuroendocrine tumors. The PET PSMA, which is used for prostate cancer. And now, Dr. Sharma, do you want to give us a little rundown on the sort of girentuximab, which is, is the essentially a clear cell renal cell carcinoma specific PET scan, and some of the results you've seen with that?
Yeah, I would love to, because we just got a study open to look at it here. So we're pretty excited about it. So like Dr. Zemp explained, the principle of these PET scans is you take a chemical that's going to attach to a chemical somewhere in your body, and it's attached to a radio dye that then lights up on the scan that they do. So the traditional PET scan is based on uptake of a sugar molecule to show how active the cells are in a certain space. These newer images are tied to certain chemicals that are expressed specifically on cancer cells. So there's a compound called girentuximab, which which is injected into the body and binds to something called carbonic anhydrase. It's an enzyme that is strongly expressed in clear cell renal cell carcinoma cells. And then when it goes there, it's bound to something that fluoresces when they do the scan. And so there was a study called the Zircon study, which some of you may have heard about, where they looked at how good is this scan for highlighting specifically renal cell carcinoma tumors and helping people to distinguish between what actually is a cancerous tumor that needs to be removed and what is a benign tumor that can perhaps be watched. And so this agent, this new kidney cancer specific PET scan, was actually highly sensitive at differentiating between kidney cancer tumors and more benign tumors, in the range of 80 to 90% sensitive and specific. So when you had a positive scan, it was around a 90 to 95% chance that that tumor actually was a kidney cancer tumor that needed to come out. And while this agent isn't widely being used yet, as we see, FDA approval and insurers getting on board, it is a good option, I think, moving forward.
So I know I think the FDA approval expected, I think we thought it was going to be maybe early summer. It looks like it's probably going to be August for that in that setting. You want to just briefly give a plug for your new study that's open, because I think that's where met.
It's still too early, unfortunately, to talk about it, but
Yeah. So I think the other thing is, can we use this like we do other PET scans and other cancers to sort of detect distant metastases, and instead of having, CAT scan and MRI plus a bone scan, can you do one scan that will capture all of that? And I think that's something that's in the works. And the other thing is, the other questions we have as physicians is, can we use these PET scans to also assess response to therapy? So I think this PET scan is a big step forward. And how big of a step, I think we still have a lot of work to figure that out. But, for years, you've had patients coming in asking for PET scans for kidney cancer, and by and large, you'd say it's not the most helpful study. I think you're going to see in the next couple of years that it may become a lot more important of a study. And you may start seeing, for some of the patients, that becomes part of your routine surveillance or follow-up imaging. So I think we're right on the cusp of that becoming a real deal, which is very exciting. Dr. Zemp, I know you gave a talk at a meeting I was at a number of months ago, and is there any other agents that that are in the works for PET imaging for kidney cancer?
Yeah, there are some of them are functional or are structural imaging. They can't differentiate between benign and malignant tumors, and so there are things looking at these benign kidney tumors, a sestamibi scan, which is looking for these oncocytomas. They light up hot on these scans, which is pretty interesting. But more on like looking for the kidney cancer side of thing, targeting the same kind of agent that girentuximab is, one of the molecules within kidney cancer. There's some small molecules. They don't really have a real name. It's like DPI 4452. And so nobody's put their own name on it just yet. That's attached to a PET scan. It's showed some really promising early results, but there will be lots of studies coming forward as this might be both a diagnostic and a treatment management in the future.
Wow. So I think we're just on the cusp of it becoming, a real thing in kidney cancer. So that kind of talks a little bit about some of those imaging sort of controversies or big changes that are coming. I guess we'll open up if anyone might have some questions for a few minutes before we move on to the second part, where we'll talk a little bit more about radiation's role in kidney cancer management. If you have any questions, perhaps the easiest way is to type them into the chat, and we can answer any questions any patients may have in regards to CAT scans, MRIs, or PET scans. And one thing I also have asked, well, we'll wait and see if others have questions, is, Dr. Sharma and Dr. Robley, do you think eventually we'll use these PET scans to say, to be able to sort of assess treatment responses? Do you think that's the way it would go? Sort of, we'll do a PET scan, then treat someone with either radiation or say with drugs, and then look at afterwards the response on the PET scans? Do you think that's where things will go?
I mean, I'll speak to maybe locally treating localized kidney cancer and let Dr. Sharma speak to evaluating response to systemic therapies. But I hope so is sort of where I'll leave that. We'll talk about it maybe a little bit in the next section, but it can be challenging to assess success of radiation treatment for a localized kidney tumor. And so having functional imaging that could prove to you that the cancer you've treated is dead, if you will, I think would be very valuable. With other kind of cancer-specific PET scans, we have found that, it's not quite that straightforward. So it can take a long time for, these things to go negative on scan, and it can be problematic to overinterpret early positive scans. So it might not be perfect, but I do look forward to that possibility.
I agree with Dr. Robin. I think we've seen from the prostate world and the neuroendocrine worlds that, they provide really great sensitivity and initial diagnosis, but then we just don't have enough data to really know how they change over time and in response to treatment, and whether a change in the PET scan is something that warrants actual change in the clinical management.
So a couple of questions. One is, insurance companies notorious for receiving paper MRIs and PET scans. What suggestions, for the best way to fight insurance companies, and what can you help to get them approved? But I think for most of us, we've come across this where an insurance company doesn't want to pay for a scan or what have you. And in fairness to the insurance companies, although I'm not sure why I'm being fair to them, some people do have scans ordered that probably aren't warranted. I have found, if you talk to most of these people, do a peer review, and sort of say, well, by the guidelines or because of the clinical rationale, most people are pretty reasonable. There are occasionally times where you won't get that. The other thing is if you can actually talk to someone who's actually a peer. So I had a person the other day who was at the insurance company, who's actually a urologist. It made it very easy to get approved. They sort of said, yeah, no problem, approved. Which raises the point, why was it flagged in the first place? But I don't know if you, at your institution, have specific strategies that you incorporate to try and sort of get around that insurance law.
I think we all kind of face the same type of challenges that you described. What I didn't mention with PET scans, when it's primary kidney tumor imaging, they're not the most helpful for looking at the kidney locally, because the PET scan is excreted in the urine, so it might falsely tell us that there isn't a mass there because it drowns out the kidney. And so from an insurance perspective, I think it's a fairly easy case to say, like, we need to get an MRI, or we need to get some improved visualization on the structure of what's going on with the kidney.
Yeah, I'd be that to meet your situation. The question is, is there just one type of contrast-induced CT scans or are there other options? There are a bunch of different ones, but they're all essentially the same thing. Just it's like if you went to a grocery store and you went to get apples. There's multiple types of apples, but at the end of the day, they're all apples. So they are all sort of the same sort of contrast agent. So if you have, say, an allergy to that, you can still have an issue with it. If, however, it's because of the renal function, then again, you need to put in context of the newer guidelines, which would say if your GFR is above 30, you can go ahead and have the contrast if it's important. That contrast-induced nephropathy is not a big issue. If your renal function is less than that 30, then you should have some IV fluids to hydrate you, but you could still potentially have it if it's important. Like most things, it's a balance. So if, it's not a super important for you to get that dye, then it's reasonable that maybe hold off on that. Yeah, one or two more questions here before we move on. Does the germ-tuximab scan detect metastatic tumors? Dr. Sharma, you want to add?
Yeah, it does detect metastatic tumors. The study that I mentioned was, mostly looking at its sensitivity with local disease. But it has also been started to be testing as a therapeutic option for metastatic tumors, similar to the way we use Pluvicto in prostate cancer.
I guess the second question is, how often are bone scans no one recommend for patients with stage 4 renal cell carcinoma?
So the national guidelines recommend as needed, or as clinically suspected. But I would say that I think most medical oncologists will order at least one bone scan at the initial time of your presentation with metastatic disease. And then potentially, if you ever present with bone pains afterwards, you would be expected to get a bone scan.
Clinical changes, very.
And it's usually a technetium 99 bone scan, just to complete that question out.
Yeah, thank you. Last two questions. Modality best to assess mets organs such as pancreas, liver. Both CT and an MRI are quite good for those. Keep in mind that the CT scan you get for your kidney mass may be slightly different than the CT scan you get for a pancreas or liver met, because when they give you the dye, the time when they put you through the scanner varies depending on which organ they're looking at. So if there's concern that you may have a specific met in one of those locations, you probably need like an organ-specific protocol for that. So you need an MRI liver or a CT, pancreas, to specifically look at those organs if there is concern and it's not answered on your initial scan that's done for your kidney. But both CT and MRI can be good for both those locations. Sometimes one can be a little bit better, but that's more down to the provider and some of the nuances they'll pick up on as to what might work better for you. Last thing, stage 4 patient unable to get CT contrast dye, because then kidney function is it better to get PET scan instead? I think most of us would say no. If you're looking at your pulmonary mets in particular, which is probably the most common area that kidney cancer will spread, even the CT chest non-con, because the background is the air in your lungs, you still get good sort of imaging of those even with non-contrast. So I'd still say that CT chest and post without contrast is probably superior to a regular PET scan. I don't know if any of the other panelists would sort of say otherwise, or any thoughts on that?
I would probably choose a CT non-contrast of the chest with an MRI of the abdomen pelvis.
Yeah, fair. Exactly.
One other point with the CT scans that you get with the PET scan is the resolution on them are not as good as just the traditional non-contrast CT scan. So sometimes you can see things a little bit better even without the contrast.
Yeah. All right, excellent questions. So we'll move into the sort of second half of this, which is Mary, I think, a number of us have emerging interests in, and it's not a traditional area. So we're going to talk a little bit about radiation in kidney cancer. And so we'll start off with a bit of a sort of what the traditional mindset probably has been and, where we've come from. So I know, Dr. Zemp, as a urologist like myself, what's historically been the role of radiation kidney cancer, both localized and in metastatic? And you want to talk about some of the maybe misconcepts or the misconceptions there that exist both amongst physicians and patients?
Yeah, for sure. So like when a lot of us were going through training, the traditional teaching was like, oh, well, radiation therapy doesn't work at all for kidney cancer. And this kind of idea has persisted for, decades. And, so there has not been as much work or looking into the treatment of localized kidney cancer with traditional radiation therapy. And it was all kind of based off of some studies there. They looked at a bunch of different cancer lines, and there was one cancer line that had kidney cancer, and that one just happened to be resistant to radiation therapy. And so that was kind of one of the maybe the flops of medicine at the time, and teaching had persisted. But over the time, we've looked at, things that predict response to kidney cancer, and we have this total cancer genome atlas that looks at like DNA damage, and we know that radiation therapy can be effective to that, and lots of kidney cancer, specifically clear cell, has that. So it's been rethought and kind of looking at a lot of different things, looking at metastatic sites, giving a higher dose of radiation therapy instead of a bunch of small little doses of radiation therapy has been used in, the brain, preventing, people having brain surgery. And it's become something that now has become an option even for localized kidney cancer. It's typically reserved for people who aren't doing so well, can't undergo surgery, or can't have a general anesthetic for one reason or another. But that's kind of where we've been and kind of where we're going.
Yeah. So again, that historical sort of mindset was based on, essentially someone taking some cancer cells on the petri dish and zapped them on radiation, and it didn't seem to kill the cells very well, break other tumors, and because of that reason, kidney cancer kind of got written up for quite some time. Now, Dr. Sharma, you as a medical oncologist obviously have a different historical perspective because you've often seen metastatic patients maybe who've had radiation treatment. So do you want to speak to sort of the role of radiation in sort of the metastatic setting and what your experience or your field's experience has been with that?
Absolutely. So, we got the same classical teaching that kidney cancer is not radiosensitive. But then for metastatic patients that maybe had a tumor in their bones or had a severe pain from an enlarging retroperitoneal node, they would get something called palliative radiation. And it turned out that they were actually responding to the palliative radiation and the tumors were getting smaller. And then eventually kind of the thinking shifted into maybe they just need higher doses of radiation therapy. And so for the last 15 to 20 years, for patients that have maybe just one or two metastatic sites, we will often ask our radiation colleagues to give high doses of something called stereotactic ablative radiotherapy. And we'll see those tumors shrink. And so there is, it is clear to us from personal experience that these kidney cancer tumors are sensitive to radiation therapy. And we do see, durable responses. I believe even out of UT Southwestern, there was, a study showing around 90% of the tumors that shrunk with radiation therapy stayed shrunk at a year.
Yeah. So, Dr. Robin, here's your time to shine. Two things. One is, can you explain to the panel and then the forum this, what the basic difference between stereotactic beta body radiotherapy and traditional radiation is? And then also, what the most contemporary data in the sort of primary setting is for localized kidney cancer radiation.
Yeah, absolutely. First of all, my colleagues from other specialties have done a wonderful job describing radiation for kidney cancer, so thank you. But it's kind of piggybacking on what they were saying. Historically, radiation was delivered at very small doses per treatment over many, many weeks to add up to the total effective dose over time. And, the advantage of that, maybe from a biologic perspective, is you give a small dose of radiation to a bigger area and the cancer cells sort of die off from that, but the normal tissues can recover. And there's more normal tissues sort of seeing radiation with these older radiation techniques, say a few decades ago. And then, as we were talking about, kidney cancer probably is somewhat resistant to that low dose per treatment type of radiation, what we would call conventionally fractionated radiation therapy. But we began to learn that kidney cancer is not maybe resistant to radiation that you deliver at a high dose per treatment over a shorter number of treatments. And with the technology of a few decades ago, it just wasn't possible to give high doses of radiation because you couldn't target well enough to do that safely. So if I gave a high dose of radiation to, say, spine tumor from kidney cancer, I couldn't do that without also giving the spinal cord a really high dose of radiation that would be very dangerous. But over the last couple of decades, the technology has advanced significantly to the point where we can so precisely target different areas within the body that we can give very, very high doses of radiation in a very focused way while sparing the normal tissues in close proximity to those areas. So that's a technology, as Dr. Sharma said, called stereotactic ablative radiation therapy, or something called stereotactic body radiation therapy. For all intents and purposes, those terms can be used interchangeably. So it's a high dose per treatment, shorter number of treatments, very focused, and overcomes the sort of classical radio resistance of kidney cancer. And then we do, as others have hinted at, have good data that this really does work in both the metastatic or limited metastatic setting as well as for primary kidney cancers. And so, when we think about levels of medical evidence to sort of support our practice, there are retrospective studies, which are basically people have treated patients, with a certain technique and then look backwards to see how well that worked. And then there's prospective studies where the inclusion criteria are more rigorous. And then patients are followed, I guess, also more rigorously. So I can't think of a better word than that. And so for retrospective data, which is a lower sort of level of data, but the bigger the series get, the more you start to believe that. So there's a very, very large international sort of consortium of centers that put together their data on how well patients have done when treated with SBRT for primary kidney cancers. It's called the IROC Consortium. And then since then, a prospective trial called Fast Track 2 was run, and that was really exciting because that's probably the highest level data we have to use SBRT in kidney cancer, and it was 70 patients all treated with SBRT for small and medium-sized kidney tumors. And then they were followed after that treatment to look at how well the tumors responded. And I think, to be fair, the follow-up on that study right now is still short. So they so far had a median follow-up of a few years. I think it was maybe 40 some months. But the endpoint that they've been able to look at for the majority of patients is actually only at 1 year. But at 1 year, there were no patients that had cancers that progressed after this treatment. So by that data, this works 100% of the time. I think with longer follow-up, it won't look quite that good. But 5-year data from that IROC consortium I referenced does show cancer control rates well over 90%. And so I think this is good data that SBRT works for kidney cancer. It works for primary kidney cancers. And again, we have some other data that it works for metastatic disease very well too.
Yeah. So this is, one of the biggest changes we've seen in kidney cancer care is the use of radiation for localized masses. As you mentioned in that study, the other thing that's impressive is the rate of toxicity, right? And so, patients having a complication that is, I would say more noteworthy, so grade 3 or greater, was 10% only, and no one had grade 4, grade 5, which is, really bad from side effects. It was all 10% grade 3. There was some impact on renal function, but, no more than what you might expect if you treat these patients with surgery. Many of these patients, they were chosen because they were not good enough to have surgery, right? And so this is a population that otherwise would be left for observation until they progress to metastatic disease. And then we have to put them on drugs like, the immunotherapy drugs, which are great drugs, tolerated very well, but nonetheless still have some potential toxicities. So this opens up another tool that we can offer patients, I think, in certain settings. As you mentioned, the long-term data on the cancer outcomes isn't mature enough yet, but people will get there. As you mentioned, the IROC data from previous retrospective studies seems to support what we're seeing in the early status with Fast Track 2. So I think it's a very exciting. One of the things, I would say is, because you can comment on this, is, some of the outcomes that are used, there are many renal masses, and in Dr. Zemp, I assume you probably abstained that are, less than 4 centimeters that we would simply watch. And if you say, progression is growing more than 1 centimeter, many of those, small renal masses are never going to reach that within, 3 or 4 years anyway. So I'm not sure if the endpoint is the most robust. I don't know if you have any thoughts on that, Dr. Zemp.
Yeah, I've thought about this question quite a bit, and the surgeon in me wants to say, no, it's not. But if we take away those, those small renal masses like the 4 centimeters, we look at the bigger ones, the ones that we'd intervene on, those aren't growing. And then I go back to some of the other urologic malignancies that we see, like prostate cancer. If you treat somebody with radiation therapy, we don't re-biopsy their prostate. Bladder cancer, muscle invasive bladder cancer, we're not always going back and doing like a repeat resection. And so I don't know if I have like a leg to stand on saying that we should really go back and biopsy everybody. it's unfortunate in some of those other disease spaces. It's not unfortunate for those disease spaces, but it's unfortunate for kidney cancer that we don't have like any blood work or biomarker that can tell us like, hey, yeah, it looks like there's minimal residual cancer there, like ctDNA, which is not always predictable in kidney cancer. So I think, if we were going to watch those 4-centimeter ones anyways, I think it's safe to continue to watch them. I had this discussion with somebody an hour and a half ago in a clinic who had a 5-centimeter kidney mass. Wasn't a robust surgical candidate. He had a 5, and I told him that his risk of metastases is still pretty low, and so he elected to watch it instead of get radiation therapy, and we offered that to him. So it's still kind of looking at the patient in front of you.
Yeah, very much so. And in fairness, in the FAST-CAR2 study, it's small masses, but they also had more than 56% of patients on that study were actually 4 to 7 centimeters. So there was quite a large number of patients in that study that were, what we'd call medium and larger tumors too. So again, I don't think it means that we have to treat everyone with this, but it's certainly nice to have another tool, especially for patients who can't have surgery. Dr. Sharma, do you want to mention thoughts of how we might use radiation maybe for the primary in future? I know there are some clinical trials currently ongoing. What are your thoughts on where we may use this, treating the primary, maybe even in the metastatic patients?
Absolutely. So, as a medical oncologist, we've seen that radiation works well for metastatic sites. And in kidney cancer, for many years, even when patients presented with metastases, we would do something called a cytoreductive nephrectomy, where we would take out the primary tumor. And we don't do this in a lot of cancers. And in 2018, there was a study that really changed the way, medically oncologists and urologists interacted. And we stopped doing these early cytoreductive nephrectomies when someone had metastatic disease because it wasn't really shown to be effective now that we have these modern treatments. But, with a lot of the studies coming out of UT Southwestern showing that local radiation therapy with stereotactic ablative radiation is so effective with treating small localized tumors, there's re-interest in whether treating the primary tumor in metastatic disease can actually have beneficial effects on overall survival, progression-free survival. And so Dr. McKay actually has a nationwide study going right now called Samurai. It's a really fantastic study because it basically takes patients and puts everyone on standard of care with your local oncologist. So you're going to get the same systemic therapy that you would have gotten otherwise. And then half of the patients are randomized to also get radiation therapy to the local tumor only. And as you heard from Dr. Robin, it's a very safe, generally low adverse events associated with that. And we're just adding it on to the systemic therapy. And the hope is to see whether, the benefits that we've seen with localized kidney cancer with stereotactic ablative radiation therapy, can we see that with the metastatic disease as well? Unfortunately, we're not going to get results anytime soon, but it is a really great study to be a part of as a patient.
Yeah, I think that's a Samurai study that was repeated then nationwide. I think it along with Crow, which is a surgical sort of study in the same sort of type of setting, are probably two of the most important studies we're going to have in kidney cancer and how we manage patients. So both, I think, super good ways to sort of, as a patient, get tomorrow's treatment today, but also contribute to the greater understanding of kidney cancer to help people like yourself and other patients and family members who may have kidney cancer. So very important work, I think. One last thing we'll touch on, we talked about the toxicity and how well this works. Most people that when they think about radiation, and particularly for men, I'd say, they think about prostate radiation, and that's, 5 days a week for a number of weeks. So it's very treatment intensive. Can you speak to the treatment regimen for, SABR SBRT for kidney primaries and how that may be a little bit more convenient for patients?
Yeah, absolutely. For either primary kidney tumors or metastatic sites, again, with this technique called SABR or stereotactic ablative radiation, it can be as few as 2 trips to clinic. And most commonly in my practice, it's 4 trips. So the first trip is to do something called a CT simulation, which is basically a 3D radiation mapping scan. And that scan sort of triggers the complex treatment planning that goes into being able to deliver such a focused high dose treatment. So it does take usually a couple of weeks of behind the scenes work where the physician will work with the treatment planners and physics staff at their institution to do all the complicated treatment planning and the software and quality assurance steps on that treatment plan before you come back to start treatment. And then this is completely non-invasive. So once you come back to start treatment, you lay down on a treatment table that really looks not so different than a giant CT scanner or something like that. You're in a big open room. It's not claustrophobic or anything like that. And we take first a scan that's integrated into the machine, a low-dose CT scan, to perfectly align your internal anatomy with how we plan the treatment. So we're aiding in that precision. And then once the treatment starts, you lay there. It's about 5 minutes. The machine rotates around you. It's not painful. You don't really notice anything other than a little noise from the machine. And then you get up and you leave. So maybe 20 minutes door to door. And we do that again in my practice, most commonly 3 times. And I try not to do them on back-to-back days. So something like a Monday, Wednesday, Friday, and your treatment work each complete.
Wow, very convenient. Very good. So I think with that, we'll sort of move on to do the questions. If you guys want to add them in the chat, there's only one here, and you know, interesting question. Is the potential to miss out on spontaneous regression in your metastatic disease if you don't do an nephrectomy or you let nephrectomy in delayed fashion? Now, I will say I do a lot of nephrectomies. And Dr. Zemp, I imagine you probably do a lot of nephrectomies. There is a reported rate of 3 to 5% of spontaneous regression of your metastatic disease site with, cytoreductive nephrectomy. And that was from, in the interleukin era. So we're going back, 25 years, 30 years ago. I will say, I probably do 50 to 100 nephrectomies in a year. I have not personally ever seen this. I don't know, Dr. Zemp, if you've ever seen it. I've certainly not seen it to the reported rate that I've seen back then of 5%. And so I think in a contemporary setting, we'd say that ability to see a spontaneous regression of, metastatic disease with just in the cytoreductive nephrectomy is probably historically been overestimated. Dr. Sharma, you would see patients with this, obviously on the flip side from it all. Have you seen patients with metastatic tumor regression after cytoreductive nephrectomy yourself?
I have never seen it, but I also don't see that patient population really.
Yeah.
Most of my patients are getting systemic therapy.
Yeah, I got that. So, so I think, it's a theoretical thing and has been reported, but not something we see very commonly. There is a question of, with the doing cytoreductive nephrectomies in kidney cancer is very different than many other cancers, and there's different rationale behind that, but some of it is that there's a sort of immunogenic basis to kidney cancer. It also explains why immunotherapy maybe works so well. And it may be why, even when you have metastatic spread, if you're on immunotherapy and you do surgery, there may be a benefit, or if you give radiation to the primary, you can expose more of the, if you will, the bits and pieces of these kidney tumors that then allow the immunotherapy to do an even better job. So that's why using the combination of these different treatment modalities together, you might get an even better response from drugs like immunotherapy in treatment of metastatic disease. But I think we're still very early on in understanding of how that all interplays together and how good that response is overall and how often it happens. But it's a very interesting aspect of kidney cancer. I think we all find intriguing, but unfortunately, I think we all agree that our understanding of it is very infantile in many regards. So here's a good question. Does SBIQ work okay on rhabdoid and sarcomatoid features in renal cell?
Yeah. The answer is probably, but same thing, in all the series of, SBRT4 or renal cell carcinoma. I mean, patients whose tumors have sarcomatoid features is just a really small number. Like I'm nearly certain that was excluded from the fast track trial, or it probably should have been. That would be for me, for example, somebody that's a candidate for a nephrectomy or a partial nephrectomy, and we get a biopsy and there's sarcomatoid features. I would probably not push for that patient to have the non-invasive treatment. I would say, listen, that's a more aggressive behaving tumor histology. In that scenario, we know that surgery, has a well-established track record. And so it's not, for me, the case where I'd really be pushing to do SBRT. Anecdotally on metastatic sites, same thing. Mostly we're addressing limited metastatic disease with SABR. And so I haven't seen that as commonly with, again, these more aggressive histologic variants, but I certainly have from time to time and treated them and see good responses at those sort of smaller number of personal experiences.
Yeah, I would say, certainly speaking, Dr. Zemp, you can sort of comment on this too at home, that, these patients that regular sarcomatoid features, with the radical nephrectomies and big tumors, those are the ones that are high risk for local recurrences. And in fact, they tend to have tentacles. I would say if you look sort of in an analogous way at things like sarcomas, which is biologically very different, but, we know in sarcomas using radiation can oftentimes help achieve better, post-surgical outcomes. There may be a role for it there, and it may be sensitive, but as Dr. Robin says, I don't think there are enough data yet to say, you did a better than, the time-tested option of surgery where you can take it out. Dr. Zemp, any thoughts from you on that?
Yeah, I think, sometimes when we're talking about these types of tumors, we're not just talking about one modality of treatment. This might require multimodality treatment, especially like some of the questions like, okay, if you've had your kidney removed, you had a metastatic site, then we know that some of these features respond well to immunotherapies. And that's where, an immunotherapy could hopefully halt the progression of that, kind of slow things down. If things are stable, then potentially, radiation therapy. But I think it's sometimes when we start talking about metastatic disease, it's more multimodality treatment.
Yeah. Right. Does SBRT work on metastatic pathway where it's a sarcomatoid feature? Only had nephrectomy on the original tumor. I think, patients who probably have limited disease or symptomatic meds is something you consider, but it probably would not replace your systemic therapies. Dr. Sharma?
Yeah, I think when we're using these alternative modalities for treating metastatic sites, it's either because our backs are against the walls and we're kind of we're just doing whatever we can, or it's because it's in conjunction with systemic therapy. Ultimately, as Dr. O'Malley said, the value of systemic therapy for metastatic disease is unparalleled in the current state of science.
Yeah, it's like systemic disease needs systemic treatments. Things, yeah. Are there any areas that radiation should not be used on? Any circumstances, Dr. Robin, that you would sort of give policy radiation either in the localized setting or a metastatic setting?
Yeah, it's a great question, and the potential risks of radiation treatment are very, very tightly linked to the specific area that we're treating. So, kidney cancer does have a tendency sometimes to metastasize to less common areas. And so I have used ablative radiation sort of all over the body. In kidney cancer, I've treated metastases to the pancreas, to even the prostate, to bones, those sorts of things. And so, I think the question is not necessarily, is there a yes or no for a certain site, but occasionally the anatomy will give us pause. So for example, a primary kidney cancer that is touching a lot of bowel, for example, that's going to be a much higher risk treatment than a tumor that's kind of sitting off the back of the kidney, sort of floating in the fat that everybody has around their kidneys. That's really not near any sensitive structures. And again, I would often shy away from a tumor that lives directly abutting the bowel, or that would be pretty consistent with the practice of most. Hope that answers the question more.
I think last question then is, any experience managing patient recall? I'd say yes. I would say that, coco comes in with kind of two flavors. You've got the sort of localized small renal mass coco where, removing that surgically, patients do extremely well. They're very indolent. And I imagine the radiation probably works just well for those that may work clear cell. And then the other it's sort of dichotomous. You have those sort of indolent, non-aggressive, and then the other tends to be metastatic chromophobe, which is a different beast altogether. Dr. Sharma, you want to talk about, the difficulties with those?
Yeah, absolutely. So metastatic chromophobe tends to be a fairly rapidly growing cancer. It spreads fairly quickly. And it does respond, quite well to immunotherapy. However, because it's so few patients, we don't really have a lot of data to guide the decisions that we make. Most medical oncologists are basically using everything we can that's been approved in clear cell carcinoma. We have a different order. We know that immunotherapies tend to work better, so we'll prioritize those. But really, any modality that's been approved in other types of kidney cancer, we use in the lesser known kidney cancers to see, because every patient is unique and you might have a type of pathology that actually responds to something approved for a different type of tumor.
Any other thoughts from Dr. Ram, Dr. Zemp?
I agree with you. Go ahead, Dr. Zemp.
All right, go for it.
I was just going to say, for localized disease, I agree with what you said. I mean, there's a small number of patients with chromophobe tumors represented in the IROC series. I've personally treated a small handful of patients who couldn't have surgery, and they seem to do similarly, although in small numbers, so we don't know for sure.
Yeah, I kind of echo what everybody said. Dr. O'Malley said there's like the indolent ones, localized, and then even in the metastatic setting, there are some that are they seem to be slower growing and might be more amenable to like being removed. And then there's some that just progress rapidly. And those are the one. It's hard to determine who those are when those show up. And if there's a systemic option, I think that's a good option. The response rates for that are, I think variable. And so it's just like every other kidney cancer that's malignant.
All right. Well, with that, we're just past 5 there. I'll say thank you, everyone. Thank you to the panelists for joining us from across the country. Appreciate your time and expertise. I hope for the patients on here and the patient advocates and the families, I hope this was informative and helpful. And certainly keep your best to some of the newer developments and some of the things that, typically come up that may be a little bit controversial. And some of the newer things. So thank you all very much, and have a great week.